Hello everyone, my name is Bruno Lima from Vanderbilt University Medical Center in Nashville, and in this session we will discuss coronary stent imaging with cardiac CT. We're going to be focusing on the fundamental principles that determine whether a stent can be accurately evaluated non-invasively. I have no financial conflicts related to this presentation. Any references to specific technologies or methods are included purely for educational purposes. And by the end of this section, participants should be able to assess coronary stent patency on cardiac CT, recognize the major artifacts that impair visualization, understand how stent characteristics influence accessibility, and apply acquisition and reconstruction strategies to improve stent interpretation. And this slide illustrates the clinical spectrum we encounter after PCI. A patient may have a completely patent stent, as you can see on the left side, or mild neo-intimal hyperplasia, might have significant in-stent restenosis or complete stent occlusion, as you can see on the far right. And the challenge for cardiac CT is distinguishing these entities accurately, especially when patients present with recurrent chest pain. And the goal is not only to identify occluded stents, but also to determine whether there is any clinically significant restenosis. And one of the most important concepts in stent imaging is that we must directly visualize the stent lumen. Simply seeing contrast distal to the stent does not necessarily mean that the stent is patent. Flow may persist through collateral circulation or through a severely narrow lumen. So the key requirement for accurate CT interpretation is direct assessment of the lumen inside of the stent itself. And this slide summarizes the three major mechanisms that make stent imaging so difficult. First, it's what we call beam hardening. And it occurs because low energy photons are preferably absorbed by metal, producing streaking and distortion. The second is blooming, that causes the metal struts to appear thicker than they really are. And third, partial volume averaging occurs because the voxel size is much larger than the stent strut itself. So metal and lumen are averaged together within the same voxel. And the final effect is systematic underestimation of the visible stent lumen. In here, we can see the overall diagnostic performance of coronary CTA for detecting in-stent restenosis across 35 studies, including more than 4,000 stents. Again, this is a meta-analysis from 2018, so this is pre-photon counting CT era. There is like new data that I'm going to discuss later, talking about the new technologies. But here, even in 2018, the overall sensitivity and specificity, they were quite good, around 90% or higher. However, these results, they vary substantially depending on stent size, the scanner technology, and the lesion complexity. So not all stents are equally accessible on CT, and diagnostic performance improves with larger stent diameter, simpler stent configurations, and newer stent materials. And you can see that the stents larger than 3 millimeters, they perform significantly better than smaller stents. Similarly, simpler stent configurations are easier to interpret than complex bifurcation or crush stenting techniques. In this slide reinforces the importance of stent diameter. Larger stents maintain excellent sensitivity and specificity, while smaller stents, they become progressively more difficult to evaluate because blooming occupies a greater proportion of the visible lumen. This is why conventional CT performs best for stents that are, again, at least 3 millimeters in diameter. And to optimize stent imaging, we need to think about the entire workflow. From the acquisition standpoint, high spatial and temporal resolution are critical, along with good heart rate control and adequate interluminal enhancement. So the patient needs to have a very good injection of contrast over there. You are shooting here, for greater than 6, 6.5, even 7, as you can cc's per second. So they need a really good IV for that as well. An 18 gauge would be ideal here. And for reconstruction, thin slices in sharper kernels improve edge definition and reduce blooming, although the increased image noise in iterative reconstruction helps compensate for that increase in noise. Finally, proper post-processing using axial views, curve NPRs, and cross-sectional images is essential. Spectral or monoenergetic imaging is another strategy to improve stent evaluation. So by reconstructing images at higher monoenergetic levels, we can reduce beam hardening and blooming artifacts from the metallic stent. And as you move from 70 to 140 keV, the stent edges become cleaner and lumen visualization improves. One caveat here is that at higher energies, although the lumen visualization improves and there's less blooming, the contrast to noise ratio decreases. So you need to have a better contrast injection, as I emphasized earlier. In this slide compares iterative reconstruction with conventional future back projection. Iterative reconstruction improves image quality by reducing noise while preserving spatial resolution. And as a percentage of iterative reconstruction increases, the visible intra-stent lumen becomes larger and easier to interpret. And this has become a very important tool in modern stent imaging. Sharper reconstruction kernels, they also improve edge definition and they reduce blooming artifact. So as you move from a smoother kernel like B20 to sharper kernels like B46 or B60, the stent lumen becomes more conspicuous. And the trade-off is increased image noise, so in practice we need to balance lumen visibility with acceptance noise levels. And window and level settings can dramatically change stent interpretation. So narrow windows may exaggerate blooming and obscure the lumen, while wider windows, they improve visualization of the intra-stent contrast column. And this is why proper window adjustment is a critical step in stent interpretation. And this slide highlights one of the most exciting developments in cardiac CT, which is photon counting CT, as I mentioned earlier. And this is a technique, that allows for ultra-high resolution photon counting systems, and they improve spatial resolution substantially. We can get slice thickness as low as 0.2 millimeter compared to 0.625 millimeter from the conventional scanners. And they also reduce blooming artifacts, allowing evaluation of smaller stents that were previously difficult to assess. In the early diagnostic performance data, they are extremely promising. As you can see in the study here, published at European Radiology in 2024. And it shows really good diagnostic accuracy. Again, it's a small study, only 18 participants, but it shows a sensitivity of about 100 and a specificity between like 70 and 80%. And this is a very interesting case, and it demonstrates the potential of ultra-high resolution photon counting CT for coronary stent evaluation. And here we have a 69-year-old man. He has severe aortic stenosis in a prior stent extending from the distal left main to the proximal LAD. And this is marked by the arrowheads here. And on the left, the three-dimensional cinematic rendering provides an excellent overview of the stent position within the LAD. In the center of the image, the curved multiplanary formation shows a widely patent stent lumen without evidence of significant in-stent restenosis. And one reader rated the image quality as excellent, and the second reader rated it as good, highlighting the high diagnostic confidence achievable with photon counting CT. And finally, the invasive angiogram on the right confirms stent patency. This case illustrates how improvements in spatial resolution and reduction in blooming artifacts with photon counting CT can substantially improve visualization of the intra-stent lumen compared to conventional CT. In this case, shows an example of severe in-stent restenosis, likely complete in-stent occlusion, evaluated with ultra-high resolution funnel count CT. And the case here portrays a 72-year-old woman, also with severe aortic stenosis and prior stenting, but this time at the left circumflex artery. And on the left, the three-dimensional cinematic rendering demonstrates the course of the circumflex stent, marked by the arrowheads. And in the center image, the curved multiplanar formation shows marked intramural hyperattenuation within the stent, suggesting either severe stenosis or complete obstruction of the stent lumen. And you can notice how the lumen appears abruptly dark within the stented segment. And the invasive angiogram on the right confirms the occlusion of the in-stent lumen. An important additional finding is that the distal vessel remains opacified through retrograde collateral filling indicated by the star. In this case, highlights two important entry points. So first, a direct visualization of the stent lumen is essential because distal vessel opacification alone does not confirm that the stent is patent. And second, ultra-high resolution CT can improve confidence in identifying true in-stent obstruction despite the presence of metallic struts. And cardiac CT can also identify important procedural complications such as under-expansion and malapposition. Here, the cross-sectional images, they demonstrate incomplete stent expansion in areas where the stent struts they are separated from the vessel wall. These findings may have important implications for thrombosis risk and future restenosis. And this slide demonstrates a geographic miss between overlapping stents. You can see a small uncovered segment between the two stents with residual plaque in the gap region. And this is important because these uncovered segments may become sites of restenosis or future plaque progression. And finally, proper stent landing zones are critical. On the left is an example of ideal positioning. On the right, osteo-RCA stent protrudes into the aorta. And CT is particularly helpful for evaluating osteo-stent positioning because it provides excellent three-dimensional visualization of the relationship between the stent and the surrounding anatomy. And to conclude, coronary CTA has become an increasingly valuable tool for evaluating coronary stents, particularly in larger and less complex stents. However, the interpretation remains challenging because of blooming artifacts, being hardening, partial volume effects, all of which can lead to underestimation of the visible lumen. So careful optimization of acquisition parameters, reconstruction techniques, and workstation interpretation is essential for accurate assessment. And finally, newer technologies such as ultra-high resolution and funnel count CT are significantly improving spatial resolution and reducing artifacts, which may continue to expand the role of cardiac CT in post-PCI evaluation in the coming years. So that's all that I had. Thank you so much for your attention.